Welcome back. This is Chapter 9, Part 2, covering amino acids and proteins. So the next section of our book covers amino acid opathies. So these are inherited disorders of amino acids. There can be two different types of disorder. It can be a specific enzyme in the metabolic pathway, or it is in the membrane transport system. Okay, there's over 100 of these amino acid opathies that can be identified. The book only covers some popular ones, 4 of them. So let's look at this first one. This alkaptoniuria. I'm sure I'm not saying that right. So it is a rare inherited disease. There is not a cure for this. What I found interesting about this disease was that it causes your skin to turn blue, gray, or black. They do notice this in babies, and it's a very slow progressive disease. But the treatment plan is just to avoid some high protein diets. But it is, like I said, it is not curable. This next one is cystinuria for cystinuria. That affects the transport system. So cysteine, if you've taken your analysis, you know cysteines can be crystals. So and that's exactly what's happening. It's a metabolic enzyme deficiency, and these crystals build up and they form kidney stones. And it is diagnosed through those kidney stones, and really the treatment for that is increased water. The next one is an interesting name. I can say this one, maple syrup urine disease. It is called that because it gives the urine gives a maple syrup or a burnt sugar odor for somebody's urine, which would be very distinctive, I would think. There is also not a cure for that. There is a treatment, just a very controlled diet, monitoring protein intake. Let's see, the next one. I'm not even going to try to say that. The initials are PKU, so if any of my phlebotomist friends know about drawing PKU in babies, this is metabolic disease. It's that inability to to break down that the essential amino acid phenylene. So that's why we do those PKU screenings when the baby is born, so they can treat that as quickly as they can. Characteristics of this is that mousy urine odor. I do not know what that smells like. I don't think that would be very pleasant. Proteins are categorized into 2 main groups. The first one is albumin, and the second one is globulins. So the first group with albumin, you have 2 analytes. You have a prealbumin and an albumin. Let's talk about prealbumin. Prealbumin is not usually analyzed every day. Usually your comps do have your albumin in it, so they monitor the albumin a little bit better than the prealbumin. But the prealbumin, its main significance is this poor nutrition status. Okay, it's a marker for that, and it's more of a sensitive marker than your albumin. There's other things that can cause decrease besides dietary, your acute inflammation, liver disease, of course, because that's where all your proteins are coming from. And then if your kidneys are pushing out your protein, then you've got, renal disease, and you're losing protein because of that. So albumin is going to be your more popular analyte. It is on the comprehensive panel. It's on the BMP, which is the smaller panel that doctors routinely order, it is 60% of your total serum protein. So that is a significant number. It is made in the liver, and its main function is that osmotic pressure, that pressure of the fluids, right? We talked about that earlier. So now you can have a couple problems not having enough albumin. You can have too little or too much. So too little is hypo. So that's going to be decreased. Anytime you see hypo, it's a low amount. Decreased albumin levels. And it's usually caused by tissue damage and inflammation. And the liver is so busy trying to repair the body and producing as much proteins as it can that it's unable to keep up with albumin production. The decrease is categorized in two different categories of diagnose. Let's see if that's function. Primarily, it's going to be your liver disease that's going to cause the decrease, but also secondary is just malnutrition and that diminished protein intake. Here's some functions of albumin. It's also in your book, box 9-2. Again, the main thing I want you to remember is this osmotic pressure. That is its main function. There's another function. Here's what the electrophoresis looks like. You can see that 60% albumin, so that's going to be a big spike. We will be talking about electrophoresis later on during this chapter, during the testing section. So there can be, well, I talked about this, hypo is not enough. There's some other variety of reasons, excessive burns, I've heard of that. It didn't talk about hyper. So hyper is too much albumin, and they don't really consider that a significant diagnosis. It's usually just because of dehydration, and it remedies itself pretty quickly with some fluids. Our next group of proteins are globulins. They are divided in 4 different groups: alpha 1, alpha 2, beta, and gamma. So I want to show you a picture of electrophoresis. So this is a test we run, usually specialty labs run these tests, but this is the result pattern. So I want you to notice the alpha 1, alpha 2, beta, gamma. That's the section we're going to be talking about. You can see just the small spike in here. So I want you to be aware of a normal. And so when we talk about abnormal increases and decreases, that is how they're measuring that through the protein electrophoresis. So our first category, this alpha 1 antitrypsin, what it is the major alpha 1 globulin, makes up 91% is this alpha 1 antitrypsin. So that is 90% of all the alpha 1 globulins is this alpha 1 antitrypsin. It's 90%. It does, the deficiency is 1 in 4,000 Caucasians. It's genetic, a lethal disease. A lot of times you'll get lab results or tests ordered for alpha 1 antitrypsin, just that very specific protein. Levels may double in acute and chronic infections. I think that does not say that anywhere, so that is important. So just because you have an increased level doesn't necessarily mean one specific thing. There's several things that could be going on. So the levels may double in that acute and chronic infections. Early onset of this alpha 1 antitrypsin, the deficiency is emphysema. So it affects the lung and the liver. All right, so that's alpha 1 globulin. So another alpha 1 globulin is glycoprotein. So glycoprotein, or they say AAG, you do see that increased in inflammation. Another alpha-1 globulin is alpha-fetoprotein. During pregnancy, you get drawn, the mother will get drawn for this level. The biggest marker for this is some congenital defects. This is the protein that the baby has, and it's detectable in the mother's blood. So alpha-fetoprotein, you can see spikes with congenital defects, but you also see decreases with Down syndromes. And it can be a tumor marker in adults, so don't cancel an order of alpha-fetoprotein because you have a male sitting there. They could be screening for cancer. And then there's our alpha-2. So our alpha-2 globulins start with haptoglobin. Haptoglobin is an alpha-2 globulin. Its purpose is an acute phase reactant, and it is the primary protein that binds free hemoglobin in plasma. So if you can associate haptoglobin and hemoglobin, you'll be on the right track. So this APR, that's the initials for acute phase reactant. You're going to see that again. It was also increased in alpha-1, if you remember. So haptoglobin also prevents the loss of hemoglobin through those kidneys, and it is seen increased during inflammation. You're also going to see a increase during conditions involving inflammation, like I said, an increased estrogen level. People that are on oral contraceptives, increase in during diabetes. Smokers will have an increased haptoglobin, and tumors. Decreases are severe, actually seen in severe burn patients. You'll see a haptoglobin decrease, acute and chronic cirrhosis. You'll see lower levels in pregnancy and DIC. Also, some viruses can cause a decrease. Epstein-Barr, cytomegalovirus. You can also see decreases as well. The next one is ceruloplasmin. We're going to associate this with copper. So if you can think of ceruloplasmin and copper, that will keep it straight in your mind. I know these are a lot of proteins we're going over, so keywords are important. So the principal copper-containing protein in the plasma is ceruloplasmin. It's composed of 95% of your total serum copper. However, it's not a transport protein, so it's not moving the copper around, but it does help with the metabolism. So the primary role of ceruloplasmin is that plasma detox reaction. It does play a role in preventing lipid oxidation and free radical formation, which also damages cells. And I think our next slide, stored in the liver. There's our next slide. So ceruloplasmin is associated with Wilson's disease. Wilson's disease is a genetic disorder. It deals with the autosomal recessive trait where ceruloplasmin levels cannot be processed, so that copper concentration is increased. So you get a toxic copper level, and you'll see that in the lab that patients often get copper level and heavy metal, and there's a special tube for that, my phlebotomy friends. The patients usually develop this disease in their 20s and 30s, although it may be earlier. The excessive accumulation of copper affects the liver, kidneys, and brain, causes cirrhosis, acute hepatitis, some neurological damage. One of the first signs is the Kayser-Fleischer rings. I'm going to show you a picture of that. Do you see that copper coloring around the ring of her eyes? That is one of the first indications of Wilson's disease. Back to my PowerPoint. So those are the things it affects. And then there's the rings we talked about. And again, this alpha-2 ceruloplasm is also increased in this APR, acute phase reaction. All right, so our last A2, I say A2, alpha-2 globulin is this AMG. It is one of the largest plasma proteins. It's consisting of 4 identical subunits that are actually 2 dimer subunits. It is involved in the primary and secondary inhibitions of enzymes, in the complement, coagulation, and fibrinolytic pathways. So don't be confused when we see some beta. When we get to the beta globulins, they have to do with some coag functions as well. But just know this macroglobulin is also seen in coagulation pathways. Our next group of proteins are beta globulins. We're going to start with transferrin. Transferrin is the major component of the beta globulins, and its principal protein is for transfer of iron. So if you can remember, transferrin deals with iron. They go hand in hand. Transferrin is an important differential diagnosis in anemia, specifically the iron deficiency anemias. So it can be whether you're on fluid iron overload, or deciding how much iron you have. It goes hand in hand with transferrin. You can also see an increase with liver disease, pregnancy, oral contraceptives. It is one of the ones that is not involved in the acute phase reactant, so it's negative for APR, which a lot of our other proteins we've been talking about they are positive, and it is a common indicator of that iron overload. So it's often calculations, not directly measured. When they order iron panels, it's not a panel anymore. It's iron, TIBC, and ferritin. The TIBC is the readout, so that is what's being measured, and the transferrin is used in a calculation. So the transferrin saturation is calculated by serum iron times 100 divided by your TIBC. And a lot of LIS systems will just have that calculated in. If they order a TIBC, it'll report out the transferrin. You do not need to know that for a calculation, by the way. Our next beta globulin is hemopexin. So anything that is hemo or heme, H-E-M-E, deals with, of course, the hemoglobin and the red cells. So it is a plasma glycoprotein along and similar to haptoglobin that removes heme from circulation. So it's similar to haptoglobin in being a positive but weak for APR. So another APR positive, but it is weakly positive. You can see the increase in pregnancy and diabetes. Beta lipoproteins, we won't spend too much on this because we covered it in a chapter. These LDLs, just remember it is a major cholesterol transfer for the cholesterol from the liver to the tissues. Beta 2 microglobulin is a protein on the cell membrane of most nucleated cells, especially high levels in lymphocytes. So those lymphocytes, white cells, they have these high levels of the beta-2 microglobulin. So plasma levels for this is a good indicator as well for glomerular filtration rates. People that get a transplant and they think they're early rejecting, they will often order a BMG to test for that renal transplant to see if that renal tubular function is decreasing to indicate early rejection. So that's when you do see an increase in renal failure. And again, inflammation, and there's your beta lymphocytes. CRP is a interesting one. They fine-tuned it over the years. When I started, it was just a CRP. It is acute phase reactant, so that APR, and it's a non-specific indicator for bacterial and viral infections, and also can be increased in inflammation and tissue injury and necrosis. So they originally found this in patients that had strep pneumo infections, and the CRP proteins were reactive when it was present with that type of bacteria. It's not specific, of course, but it will just give you a generalized hey, you have an infection, so it's not very specific. But it should not be increased for a normal person. So lately they have, this can also be, the CRP can also be increased in myocardial infarctions, so your MI, your heart attacks. So recently they have come up with a new reading. It's called the highly sensitive CRP. So it's measuring the same protein but in a newer monoclonal antibody that is more sensitive. So you should not have highly sensitive CRP in your blood. If you do, it is a precursor of an MI or that heart damage. There is levels dramatically increase MI. We said that. And it's a valuable tool with bacterial infections, even though it doesn't really differentiate. All right, so it doesn't, I'm going to back up, but it talks in our book about fibrinogen and complement. Doesn't have a slide on that. I just want to touch on that to make sure we know fibrinogen, is a coag. You'll find decreased levels in DIC patients that are going in DIC. It is a type of protein that is a APR, and you'll see an increased fibrinogen in pregnancy. Complement's another one. We'll just touch on that. It is, again, an APR. It increases with inflammation. You'll see decreased levels when coagulation factors and proteins are consumed. You'll see a higher level of complement. So our last section of globulins are the gamma globulins. They are separated into groups, immunoglobulins. A lot of you guys might be familiar with this if you took immunology. This is a big immunology protein. So we're just going to kind of highlight these. Your IgGs are going to be your most abundant immunoglobulin. They have these two separate change and binding sites. There's your classes M, G, A, D, and E. So we'll start with G. We're not concerned too much about the weight, but what I want you to be aware of, it is the most abundant of the immunoglobulins. It consists of 70 to 75% of what's measurable out of this class. They are produced in response when you have a bacterial or viral infection. However, they're not the first to respond. They are secondary, as we will find out with IgM. So IgM is the primary response tool. So when you are exposed to a virus or bacteria, it's your IgM that gets pushed out first, and then your IgG follows, right? And that's from immunology. Just be aware of that. Your IgA are in tears, sweat, saliva, milk. Immunoglobulin D, I love how they say primary function unknown, so I don't expect you to know anything about a D. And then there's E, and that is for allergic reactions. And you'll see IgE ordered on allergy panels and food panels. They will usually include a IgE level to just gauge the allergic reaction that's going on. So that wraps up our last. I want to give you kind of a summary, and let's look back at all these and let's hit the highlights. I know that was a lot of information. So here are some electrophoresis charts. Here is what a normal looks like. So you've got a nice large percentage of albumin. There's your alpha 1, alpha 2, your beta, and your gamma. Okay, but look at our acute inflammation. And that's what we call that APR. So during acute inflammation, you're going to have an increase of A1 and A2. That's important to remember. So please keep these 6 are, just kind of remember this chart and what's elevated and what's not. So this is important. Both are elevated in acute infection. You'll see a decrease with emphysema for your alpha 1. So make sure you keep that in mind. And your alpha 1s also have your alpha fetoproteins included in them. Your alpha 2s, just for a summary, you're going to see a decreased number of those, decreased level in burn victims, DIC, some viruses. That's with your haptoglobin. It can also be decreased with liver disease, neuropathic syndrome, pancreatitis. So just keep that summary of A2. Your alpha 1 antitrypsin, remember that was your biggest group of A1. So if you have a decrease in A1, that is the majority of what consists in that alpha 1. Liver cirrhosis, so you can see a lower albumin, and then look at your gamma globulins. They're just kind of very increased, and these are, you can see it's the liver is affected in many ways, but it's mainly albumin and your gamma globulins. We haven't talked about the multiple myeloma, but we will in a second, but it is increased with your gammas here. We're going to talk about that in our next section. And then, of course, our last section, that kidney disease. Proteins are filtered, should not be filtered. They should be reabsorbed. So when you have renal disease and renal insufficiency, you're going to get abnormal protein. You're going to get a decrease in those, an increase in your A2 because of, the size. All right, so that wraps it up. We'll do our next section. We'll be going over some testing, and that'll be a quick section, and that'll wrap up this chapter.